Okay, let's start with diverticulosis, even though it's written the other way around first, because you really have to start with diverticulosis. What is that? Well, a diverticula is kind of like an aneurysm of the intestines. Okay, normally it is in the sigmoid colon here, the part that looks kind of like a backwards S, kind of ish. Anyway, that's where they normally are. And if you're getting like outpouchings, just like in an artery, you can get weakness in the wall and it pouches out. Okay, so it kind of blows that little sucker out there and you get this little outpouching. Well, that's diverticulosis. You get a diverticula, and diverticula is called diverticulosis. Okay, all this, it's called an outpouching is what they call it when you get that little puffy part that just kind of shoots out. If it becomes inflamed, infected, now it is an itis. Okay, and the problem with this is maybe there was something like a little seed or something like that got caught in there in that diverticula, and bacteria got in there, and maybe it started growing, and next thing you know, it's all inflamed and infected and getting bigger. Okay. The problem with that is, one, it hurts because it is now inflamed and infected, and two, if that thing pops a hole through there, can you imagine if you have a diverticula or something right there, diverticulosis, diverticulitis, it pops a hole through, and now you have fecal matter all over in the inside of your gut. You're going to get septic really fast, which means a very severe infection from that, and that can be a problem. Okay. Now, as far as diverticulosis, going back to that, it is pretty common, especially in elderly people. In fact, they say greater than half of Americans over 60 years old have diverticulosis. Most of the time they don't even notice because the losis part doesn't hurt. It's itis where it starts hurting, and of course perforation is very painful and immediate medical emergency. Okay, but you can get, if losis causes pain, then you have abdominal pain, cramping, nausea, vomiting. Definitely diverticulitis would cause these. Okay, and the perforations part is the obviously problem, because now you're bleeding into your gut, and peritonitis, or inflammation of the peritoneum, which is basically the membranes that go around your inner organs, and if that gets inflamed, then that really hurts, and now you have, by the way, stool, like I said before, in your bowel, and it's going to cause sepsis, right? There's supposed to be an E there. Okay. Certainly that scarring can lead to blockage if you have that diverticulitis, and a fistula means sticking to other organs, and that can cause an infection too. So if you think about this, the bowel is not all by itself in the gut. Okay, it has the stomach up here, behind it has the kidneys. Oh, those are really bad looking kidneys, but it has the kidneys behind them. It has I don't know, spleen's way over here, pancreas is way over here, liver's over here. It just really depends on what you're talking about, but you can definitely have sticking to other organs from the hosta or whatever it is that's on the outside of the large intestine. And a fistula actually is kind of like a little tunnel. So you could have a fistula, and maybe in this spot, it actually does break through, and then maybe it connects back in here, or maybe it connects, actually somewhere else in the body because it broke through, and now you got basically an unauthorized tunnel going somewhere. Not necessarily a good thing to have, right? How do you test it? Well, routine colonoscopy, stick a camera up there in a tube, and you should be able to tell if there are diverticula. CT should be able to find it. Abdominal ultrasound should also be able to find it. Again, we're looking for something physical that's just kind of sitting there, a little outpouching. Treatment and prevention is a high fiber diet. Okay, you want to have lower pressure, just like an artery with an aneurysm. Lower pressure, less chance of it bulging out like that. Okay, antibiotics are usually the treatment for diverticulitis. Most of the time, it can handle it. The antibiotics will handle diverticulitis and keep it from getting serious, keep it from perforating. But of course, there's always the option of surgery if all else fails to get rid of them before they, well, and then fix them if they did pop. Alrighty. Not really sure what to say about these. These are just camera shots of different parts of the colon. And I guess this is, I mean, we're not talking about that at the moment, but the rectum and hemorrhoids, or the hemorrhoids in the rectum, is a hemorrhoid is just an inflamed artery that bleeds. Okay, so an inflamed artery, and that artery bleeds. Okay, or actually a vein usually. Okay, diverticulosis. Do I have anything else on this slide? No, I did not have anything else on that slide. You can see where they're kind of popping out. You know, they're not supposed to be going, have these little pop-outs going to the outside. Okay, that is not a good thing, because you get stuff stuck in them and they get infected. Ulcerative colitis. Okay, now we're starting to get pretty interesting. One thing to keep in mind about the ulcerative colitis is only in the colon. Okay, that's why it's inflammation of the colon. It's an itis, therefore it's inflammation of the colon causes ulceration. So ulcerative, it causes ulcerations. All right, more common at the rectum and sigmoid colon. So we're talking the very end of the colon that they're most commonly found at. Don't really know for sure what the causes are. Unknown. They say that ulcerative colitis can be caused by infections or even a genetic factor, maybe immunologic factors. We really don't know at this point what the cause are. Talking about people in prime of their life, really, 20 to 40 years old, is who this affects with the new incidence of them. And there is, when you're talking about that family history, that genetic part, there is some association with Jewish ancestry that is more associated with ulcerative colitis than other people. Okay, left-sided, more pain. Why? Well, if this is how the colon looks, then the patient's right side is over here, which makes his left side over here, and we said that the rectum and the sigmoid colon area is where it usually affects it. So that's why you would have the left side lower abdominal pain. Okay, these ulcers can cause bleeding, it can cause diarrhea, urge to defecate, abdominal pain, melena, and dark bloody stools. Makes sense. The signs and symptoms, they can come and go. Okay, so it might go into remission for a little while there and then get worse again. Okay, that's ulcerative colitis for you. Or chronic, very chronic ulcerative colitis for more than 10 years can actually increase your risk of colon cancer. You think about that, doesn't really make sense. If you have a bunch of little ulcers in there, or polyps, then there's just more opportunity for cancer, abnormal cells to take over. Okay, pseudopolyps. Okay, they're called pseudopolyps. I'll show you a picture of them. But you get those because the ulcers keep healing over and over and over, so that's why you're getting these pseudopolyps. As the ulcers are healing, it turns into these polyps. Alrighty, testing, complete blood count, CBC, find some kind of itis, signs and symptoms, right? Your white blood cells are increased. You're going to find in your colonoscopy that you're going to be able to see it. It'll be fairly obvious. I'll show you again in another picture or so. But you do want to rule out infectious disorders because this abdominal pain, bleeding from the stool, urge to defecate, these symptoms certainly can mimic other things, so you do want to rule out other infections that it might be causing these. Alright, treatment. Medicines, surgery, yes, take them out of there. Ilio pouch anal anastomosis, anastomosis, as in as in moving it, basically, bypassing it. That's another option, is to bypass the problem. Okay. Smoking for treatments. I don't know anything about that. You're going to have to ask your instructor in some detail. Whoa. Okay, here's my ulcerative colitis pictures. Okay, again, you can see the little ulcers here. And usually they are talking about the big S, the sigmoid part of it. Uh-oh, what did I do? Went the wrong way. Okay. Some pictures of ulcerative colitis. Okay, it's just in these pictures it just kind of looks like rough parts. I don't even know what you would call them, but you know, they're ulcers. Okay, again, some ulcers. This is the ulcerative colitis look of these pseudopolyps. Okay, pseudopolyps, they look very much like, when you put them really close together like this, it looks like shag carpeting. Okay, so these pseudopolyps are a byproduct of the healing of the chronic ulcers. Okay. Crohn's disease, our other bowel problem that we're talking about here, is inflammation of the GI. Duh, so are the other ones. The big thing with Crohn's disease is it can be in both the small intestine and large intestine. Okay, so if you are talking about Crohn's disease and the ascending and transverse colon are the most common sites, that makes it a little bit easier, because your colon kind of comes like so, like I've drawn before. And if your colon is doing like so, and this is the patient's right and the patient's left, then as soon as you enter from the small intestine and go into the large intestine, then you're going to see the ascending part of the colon. That's my little bracket, if you didn't know that. And then you're going to see the transverse part of the colon, okay, where the that's Crohn's. Again, it's more common there, but it's also more common for Crohn's, for ulcerative colitis to be in the sigmoid colon. Okay, but again, that can be anywhere. That's just the most common parts where Crohn's disease can be. The causes, again, really not positive about the causes. It could be infections, genetic, immunologic. I think this is sounding very familiar. Family history, 10 to 20%. Well, it sounds kind of like a possible cause there. And smoking increases the risk of developing a severe disease. You can pretty much say that for every disease, right? Okay. Abdominal pain, yes. Cramping, diarrhea, dozens a day, bloody stools, same kind of thing in ulcerative colitis. But what you don't have is skip lesions. Okay, skip lesions are where the ulcers start forming in the bowel, and then they skip a little bit. So if this is my bowel, I already got a bowel up here, let's draw there. If that's my bowel and I start forming ulcers way over here and kind of lay down a track of them, then I might skip all the way to over here and start doing it again. It's really hard to say whether it'll pick up or not again. But skip lesions, they don't stay continuous. They skip from one place to the other. Okay, and of course it's transmural all the way through. You get inflammation. It's pretty severe kind of problem here. Weight loss, yes. Again, you're having problems absorbing nutrients, possibly bleeding, hurts, pain, don't want to really eat. Okay. And if the ileum is involved, as in before the large intestine starts, if the ileum, the last part of the small intestine, is involved, then ileum, then you have a problem, because that's where your vitamin B12 and your folic acid and your vitamin D are all absorbed. Okay? CBC, you'll find some kind of inflammation. Colonoscopy, you will definitely see what's going on if it happens to be in a part where you can actually see. Again, the colonoscopy is not going to go that far. You can only take that thing so far in the bowel, and if it's actually the problems are way somewhere away, it's going to be difficult to see it. Okay? So, there's that. There's a little picture that we kind of look at just to get the bearings straight again. There's our cobblestone appearance. That kind of looks like cobblestones in there, right? So they call it a cobblestone appearance for Crohn's disease, where the ulcerative colitis look like more like shag carpeting, right? Okay, we're going to temporarily break this off for now.